Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hey guys, and welcome to another edition of the AAOMPT podcast. This is Kevin MacPherson, and we are continuing our coverage of the 2018 AAOMPT Conference in Reno, Nevada. In this episode, we are going to be interviewing Adriaan Louw. If you're not familiar with Adriaan's work, you are probably a little bit behind on your researching of pain science and how it is applied to clinical practice. So background, Adriaan is the co-founder and CEO of the International Spine and Pain Institute. He earned his undergraduate degree and master's degree in physiotherapy from the University of Stellenbosch in Cape Town, South Africa. Since then, he has undergone PhD training and currently is the director of the Therapeutic Neuroscience Research Group, which is an independent collaborative initiative that studies pain neuroscience. So without further ado, let's get into our interview with Adriaan Louw. All right, so we've got Adriaan Louw with us joining in the middle of the conference. And with the title of the conference being Changing the Pain Game, I don't think there's a more fitting person to really talk about pain on our podcast. Now, Adriaan is going to be involved in at least 4 different discussions or different activities to do here. So we're going to get a little bit of background on Adriaan. And really, Adriaan, the first thing I want to ask is, how did pain become your passion? Was there any specific event that brought you to pain that made you really want to look into it?
Easy answer, I failed. It's a lot of people have asked me that question. I was trained as an orthopedic manual therapist, thought I owned the world, thought I was the best thing since sliced bread. And I did. For about 5 years, I could help a lot of people. And then it's like someday somebody flipped a switch. And people walked in with complex stuff I couldn't work on, and it just didn't work anymore. And I became very disillusioned with my profession, and this isn't working, and I hate my job. And, I kind of jokingly tell my students I drove by Lowe's every day and see if they have an opening, but it just stopped working, and I had nothing to do anymore. I was really frustrated. Now, having said that, I think what happens is when you get good at something, and I think I was a decent manual therapist, you start seeing more complicated patients. We know it happened to Jeff Maitland, to all these guys. And so I started seeing more complex patients, and I wasn't trained for it. And so as far as the passion goes, I was given a paper, an old paper, 1995, Adverse Neural Tension by one of my instructors in South Africa. I went back on vacation and told her I hate you. And she gave me this paper and said, yeah, there was this guy from Australia, you should read this. And I read it, and I was like, this doesn't make any sense. And then my wife now, who worked with me, is also a PT, bought me his book, and I read like 4 pages, and I'm like, oh, this is crap, this is stupid. And then I went to a course in Dallas, Texas, which David presented, Mobilization of the Nervous System, 1996. And I remember going, kind of irritated, I hate my job, and I will never forget it. I sat in front of the class, waiting in front, this guy walked in, beautiful Australian accent, and we're part of the Commonwealth, so we greeted, and hey, how you doing? You knew my instructor, we started chatting a little bit, and the first picture he put up on the slide was Louis Gifford's mature organism model. 1996, it hasn't even been published yet. It blew my mind. You mean to tell me that a joint has a brain? You mean to tell me that every patient has a brain? I mean, I know it sounds silly now in 2018 when we understand pain neuro matrix and all that stuff, but it was so foreign, and it absolutely blew my mind. And just to finish the story, I met Louis Gifford in 2008 in Nottingham, and I mean, I just remember how cool it was to meet him, and just talking to him, and how I became full circle, then became friends with him. But that was it. I failed, and then luckily I was at the right time at the right place with really cool people that was kind to me, that showed me cool stuff, and that's how I got there, and then that's where we go.
All right. It's interesting to hear your background, because I have I think a lot of us end up, like you said, going through the similar tact. And I was exposed to pain science via more the placebo, nocebo expectation aspect. So being around Joel Biloski and those individuals. But I also got to the point where, knowing that stuff, I don't know what to do with it just yet. And then further diving into Louis' work, which I literally just bought his books
Yeah.
at the beginning of this year, and it was the stories that he gives are literally the stories like, I've got that patient, I've had that patient, I'm going to have that patient. It's nice to see that story across clinicians is consistent, but it's also nice to see that you and others are trying to help out the group to say, hey, let's now start working on those complex, because that's what we're going to get. Now, you had a pre-conference course, and it was looking at pain and manual therapy. And looking at some of the recent discussions, specifically Chad Cook's, there's kind of this dynamic in the social media world of, well, if you're treating pain, you shouldn't be doing manual therapy. I know currently your processing is no, that's part of the treatment. Can you just give us a brief synopsis of kind of the main themes to pull out from your pre-con course?
Yeah, I mean, I am absolutely 100% convinced that there is a subgroup of people in chronic pain we should be very careful putting our hands on. Mm-hmm. We know people with extreme allodynia, people that become dependent on hands, locus of control, etc. But I also think we shift the pendulum too far by saying it's hands off. So a part of our research right now, which is really what the pre-con was about, is the fact that we believe that manual therapy is a form of sensory discrimination. And that brings up the concept that manual therapy shouldn't be passive but active. And what I mean by that is we often put patients on a table, we kind of shove their face in the hole and say, I don't really care what you think, just face in the hole, I'm going to work on your back passively. Mm-hmm. Mosley's research has shown us that sensory discrimination, where the brain is involved, is far superior to sensory integration, where we just give you different stimuli. So what we've now done, with probably about a handful, 6, 7, 8 papers, is we have now shown that when patients have to actually sensory discriminate where they're being touched and how they're being touched, it actually has a very powerful treatment effect. So for example, in this scenario, we'd have a patient on the table and we would be doing a technique on L1 and then a technique on L5. But instead of just passively doing the technique, we'll introduce the patient to the stimulus. This is L1. Can you feel it? Yep. Say it. Come on. L1. Good. This is L5. Can you feel it? Yep. Say it. Come on. That's L5. And then we will randomly put our hand on either or and ask them, where am I? And they cannot see us, obviously, right? So they have to feel through their skin. And we know by sensing, you sharpen the primary somatosensory cortex. And that sharpening, that shrinking, is powerfully associated with decreased pain. And that's a line of research we're doing. So we believe that manual therapy can be a beautiful form of reshaping the brain. And that's kind of where we're going. I mean, Joe Bialowski, Bishop, George, they've done amazing stuff with all the placebo stuff, Therapeutic Alliance. So we have just one little added piece about neuroplasticity. And so I think the modern manual therapists have to screen for plasticity changes, which we don't have fMRIs in clinics, but we have body charts. We have two-point discriminating calipers. We have paper clips. We can literally test sensation. So there are ways for us to measure a plasticity shift. When life is good, our maps are sharp. When we're in pain and we don't move, the maps become altered. They become blurry. And that drives pain up. And if we can sharpen this map, the pain goes down. And manual therapy as a tactile intervention has that possibility. And that's what we presented yesterday, and intriguing. Yeah, and we've got a whole series of that research going on right now.
Yeah, I'm looking forward to those results. Clinically, I've attempted this. I listened to one of your previous podcasts, I believe, where you talked about this. So clinically, I've tried to do kind of the I'm pressing on L1, I'm pressing on L5. One of the issues I ran into with that, and this is probably just because I'm naive to the whole experience, was the patient giving me the facial expression of like, what are you doing?
Yeah.
I'm not following. So what does that conversation look like to get them there? Is that after you've done your work with the images?
No. So we have done that. That's the experiment. The paper we published in JMMT was about that. So what we did is we had two groups of patients, both with chronic back pain. One group, we gave them a very mechanical explanation of therapy, and we did a mechanical technique, a central PA. But the other group, which was intriguing, I still find this very intriguing, we sat with novice, run-of-the-mill, normal Americans coming to a clinic, and we just showed them a picture of the homunculus. Now, your listeners have to listen carefully. We just sat with normal, middle-of-nowhere Iowa people. Sorry, I'm from Iowa. And we showed them a picture of their brain. And we explained to them plasticity, and they got it. So we told them, here's a map of your brain. Life is good, the map is sharp. So this is, and I put up my hand, I'll say, this is a hand, right? Yep. And I go, yep. And they say, close your eyes, and put your index finger on your nose. And they do it. And I say, how did you know that's your hand? Your eyes were closed. And I go, oh, I said, you have a map. And when life is good, the map is sharp. Well, we now know from great new research that these maps actually shift when we're in pain. They get a little blurry, like, where's the back? What's going on? So we're going to do this technique with you today, but I'm going to do these really cool little bouncing techniques in your spine. And what it really does, it sharpens the map as I get onto L1, L2, L3. But you're going to have to help me today. And so we give them an explanation that makes sense. And we tested it, by the way. We explained it to patients. We had a scale of, does it make sense? And people rated it very high, like, well, that makes sense. But it was a complete anti-biomechanical explanation. And if you look at the study was really about the words we choose. We had the same technique, but the group that got the neuroplasticity explanation did far superior. So in a clinical scenario like yours, I would have to preempt and explain it to patients. And what we are showing from the pain neuroscience research, our patients can take it on. They're smart. They go, oh, I got it. That makes sense. And if they don't, then we explain again. If they don't, then we have to consider, do we change the story? It's just intriguing as we're playing, but you have to explain it. And that's the critical part.
How long have you been working on your scripts? And are there sub-classifications of your scripts?
Yeah, we have, I started my PhD work in 2007, I think it was 709, somewhere around there. And my PhD was based on building these stories. Which is kind of funny, you give somebody a PhD for building stories. But we had 12 studies that we tested and trialed and worked, and I'm very fortunate. I worked with David Butler and Lorimer Mosley, whatever, and we built these stories. So we initially built a surgery story for patients before surgery. That was my PhD work. And then we expanded them. Today we have 46 stories for different things. And so what we teach our residents quite often is, okay, so when a patient walks in, we got to match the story to their problem. Sally was in a car accident. She now has a whiplash associated disorder. And I asked her in the clinic, Sally, since the accident, what's the biggest thing that bothers you? And she said, oh, geez, I forget things. And I got this fog. There is a story for that. So we have the brain meeting story. That's the perfect story. That's like manual therapy, where for a certain condition, you do this technique for this. And that's how we teach. So we build stories for spreading pain, for mental fatigue, for problems with sleeping, problems with allodynia. So we literally look at what's the biggest problems people face in pain, and then we build stories. And once we build the stories, we build more stories, because men and women are different. So there's, for example, an alarm sensor story that women will get. Sorry, I don't know how people get offended, but the male version is a sensor in a car, which most guys go understand a car, like, whatever. So we started tweaking the stories to make it. We have military stories. We doing this stuff right now in the Department of Defense, and we have found the military personnel respond better to stories about Pearl Harbor, or there's an attack on the perimeter fence. Those kinds of things they can associate. We've built stories for school kids, those kinds of things. So we have an original series, and then we started adapting and refining. Yep.
So your core story is the same. It's just the small context is changed.
Yeah.
Okay.
Yep.
It's absolutely fascinating, and I'm sure most of the listeners to the AAOMPT podcast will recognize that the expertise for the manual therapy is quick and easy. It's that language, it's that relationship that is a lot of what fellowship gives you. It's very easy to go in there and say, I'm going to push here, but to be able to explain in such a deep way that resonates with that patient, and to know that you're working on those stories in order to help it out, it's fascinating, and I look forward to learn more about it.
Yeah, and I just want to be careful. I don't want us to look at manual therapists as quick and easy. I think there's an enormous skill set to it, and as my speech tomorrow will be about refining your skill set. I think we got to be very careful to it's just that part. But yes, the blend is the answer. We all know that intuitively. It's got to be the good hand skills, a good set, and we have to work on our craft. Butler told me years long, we got to become, if you're good at your hands, become good at your hands, be good at your hands, and keep getting good at your hands, because it does show up. But then it's the other skills, like Joel Bilowski showed this morning and stuff. So
yeah, and I think I'll retract my statement. I didn't want it to come across as excessively easy. It's just when we look at that contextual variability, it's just so much when we look at those.
How about we just say it's newer?
Yeah.
We're very familiar with manual. And I think for the modern clinician to think that a cognitive intervention has therapeutic effect, as we now say, education is billable therapy. Mm-hmm. We never thought of therapy as a billable therapy, but when you do these cognitive retraining of how people think, they actually move better, they function better. So it's just a newer skill.
Okay.
That's all. I wouldn't say it's yeah.
Okay. Yeah. Enough said. I follow you now. So your coming talk is called Back to the Future, and it's in reference to innovation. Without spilling the beans, because we're actually going to put this on after the conference. Can you just give us a little insight? Yeah,
it comes from a question. I was sitting in a podcast like this, and somebody asked me a question, and I don't know where my brain was. I was thinking, and the presenter asked me, Adriaan, what makes you good at pain science? Now, I should have stopped and said, I'm not good at it. I'm working my own way through it. And before thinking, I said, I think I'm good at this because I'm a good manual therapist. And then it struck me, and I'm like, whoa, I had to think about it. And then they asked me why, and I said, well, I now tell clinicians every weekend when 90% of my patients start crying after the physical exam. And the question always is why? Well, because they sit there and they sob. They don't cry, they sob. And when I console them and ask them what's wrong, they say, that's the most thorough medical exam I've had in 10 years. And Corey Zimney, one of the super brilliant smart guys, is one of my instructors, but he's also one of my PhD students. I got a little hold on him still. He's way smarter than me. His whole PhD is coming down to what makes pain neuroscience work. This explain pain thing, go, I got it. Mm-hmm. And it's when they trust you. Mm-hmm. And how do you build trust? You do thorough examinations. You skillfully handle somebody. You interview them very carefully and beautifully. All that stuff builds trust. And so my keynote tomorrow is to show that it's okay for AAOMPT and groups like this to run towards pain, and that's fine, but don't forget your roots. The Maitlands, the Mackenzies, the Syriacs, whatever. There's beauty in that stuff too. So that's why we came up with we probably stole the concept, but Back to the Future, like, it's okay to go forward, but don't forget to go back. So don't give up on your skill set, your handling, etc. Now, there is a message here too. We got to embrace biopsychosocialism. We got to embrace pain science. As you and I know today, it's got to be both, right? Mm-hmm. But my story, because I think what happened is, I think people expect me to come on stage tomorrow and talk about the brain and plasticity, and I decided I'm going to shock them a little by telling them it's also about the manual. And so I'm still tweaking some of my thoughts here, but so there's a little bit of a wake-up call about, we need to see where we're going, but don't forget where you're coming from. I think manual therapy has so much to showcase. All the studies about therapeutic alliance, the non-specific effects, the stuff Bialowski talked about, I think manual therapists may do better than most. And I that's why I think my patients really like it, and I think they do well, because I examine them well. I treat them well. I skillfully handle them. I remember I was Butler's lab assistant for years, carrying his bags, and I was always the guy laying on the table when he had to demonstrate technique, and I will just never ever forget how beautifully he handled. Now, I knew Dave many years, and he's like a dad to me, but just the way he handled me, it was so wow, and that's what I wanted to emulate with the pain stuff. And so that's kind of where I'm heading, I think. At least right now. I've changed this topic. I've changed my PowerPoint 100 times. I'll probably change it tonight again. So
it seems like all the good ones typically do. It's nice because you're continuing to evolve that. I'm sure it drives you nuts, because if it's anything like my talks, it does drive me nuts to keep changing slides and whatnot. Now, I'm going to ask you a question. This might or might not actually make it onto the podcast. It's only because I listened to another podcast they were interviewing a woman who talked about the sobbing. Yeah. And her aspect was more of the psychological component of it. And what she said was, I never give them the tissue until they're done with that experience, because they need to feel the experience, feel that emotion. Is there anything that you would say to that?
Yeah, I think in a perfect world, none of us want our patients to cry, right? But we now know, body of evidence have proven that behavior shifts due to emotion. Mm-hmm. My brother is a smoker. I love him to death. I sit with him on the couch, have a beer, and you got to stop smoking. And he's like, yeah. What needs to happen is he needs to hack his lungs out, maybe bleed a little bit, and sit there and go, wow, I got to change my way. I need to get fat enough to where my belt won't fit, and I got to stop. This is not. So emotion drives behavior shift. So I always tell young clinicians in the clinic, and I'm not answering a question, but clinicians get very nervous when you tell a patient about pain and they get mad. I always tell them, inside of you, just go, yes, because you created emotion. And that's what you want. The scariest patient is the poker face that sits there and looks at. You don't know if they're going to stab you, if they're going to scrape your car, if they like you, whatever. And so emotion's a good thing. We prefer not to have it because it's a hard thing to deal with, but we have to. We know when you cry, you release serotonin, right? And all those kinds of things. But pain is real. This is real stuff. Suffering is real. And it's inevitable that people will cry and there will be an emotion, and that's not a bad thing. By the way, there's strong research to show that if you do create an emotion, there's a way stronger bond with the healthcare provider. It's stuff like that that is critical in the right context.
Yeah. I've got 2 patients right now that fit into the category that you're describing, and one of them is on the upswing. Last time I actually got a smile out of him after about 3 months, and he was just exactly what you described, whether I paid attention to that previously or not, where I'm just like, I don't know if I've got this person. Yeah. And then to start seeing that change, it definitely livens up. It makes me further love what I do. All right, so here's the tough question. It's the one that I personally have struggled with quite a bit. Has relatively autonomous practitioners, physical therapists, do have the ability to interact with patients independently, but we have to recognize we're part of a larger system, and that patient's health experience and healthcare in general are all part of a larger system. As a practitioner who will go through the pain science, the neuroscience, the neurophysiological education component, looking at that change in the homunculus, knowing that I've got a patient who's simultaneously getting care from somebody who's a little bit more pathoanatomical based, and through my opinion only, probably isn't the right direction to go. How do you handle it when that patient comes back reabsorbed in that pathoanatomical model?
Yeah. There's a lot of ways. Number one is we see a high percentage of patients in our clinic with CRPS. And so we're kind of end of the line for a lot of people. So it's easy for me to go to a patient and ask them for just a little while to only see us. Now, it seems very artificial, but that's one option. So we often sit with the patient and say, listen, I know you see a chiropractor once a week for an adjustment, and that's fine. We never cut any healthcare provider down. You'll never win. And I say, you know what, he's great, she's great, whatever. Can you just do me one favor? I just really need you, just give me 3 or 4 weeks. Let's just do it our thing first. And most of them are okay with it because they've been doing it for so long. It's okay. By the way, I have no problem calling the chiropractor as an example and say, hey, listen, I know a lot of them in our community, and say, listen, I got Sally here, and I'm nothing against you. Is that okay? Whatever. So we work together all the time. So if it's somebody like that, or the massage therapist, for example, I will have a patient say, you know what, if you want to go see a massage therapist, that's fine. But think of it more as I've been doing my homework in therapy, I've done my job, I deserve a massage. Don't think about something's tight. So we change how they think about what they're going to be doing, right? And so that's one way. If it's higher up the chain, like, they can see the orthopedic surgeon and, it's the bulging disc, it's the biggest one I've seen, then you have a doctor problem. And so then we have to go to the physician and talk to him or her. And so I'm more of a cup half full person anymore. When I came to America in the late 90s, what I found is a lot of doctors, you have a bulging disc, biggest one I've seen, we need surgery tomorrow. I'm finding more doctors are now saying things like, you got a bulging disc, but so do I. We see MRI reports now that shows normative data, right? Like, you have a bulging disc, but so do so many people. So I see more positive shifts. I do believe, sorry, this is a very negative thing to say today, but I think the older garb that says the bad stuff is kind of dying out. Yes. I shouldn't say that. The younger guys are more in tune to it. This is old Maitland's thing again, right? Walk the walk before you talk the talk. Treat your patients right. The holy grail is when a patient says, you know what, I believe you, not the doctor. That's the holy grail. That's the, oh my goodness, I'm so cool, right? And it happens every now and then. So my point is, treat your patient the best way you can. If they go back to a specific healthcare provider that always scares the living daylights out of them, then you have a doctor problem or a nurse problem, whatever. Then I go to the physician and say, hey, doc, listen, I appreciate the referrals. I'll help you any day. Call me any day, time, day, night. I'll see your patients. But I need to tell you something today. So one of the interesting things is people always ask me what I do for a hobby. Well, I shadow doctors. That's my hobby. I love learning. And so I go visit neurologists and orthopedic surgeons and neurosurgeons, whatever. The number one thing I hear that I figured out in 25 years of doing this is they really care about their reputation. And when I go to an orthopedic surgeon and say, hey, doc, I need to tell you something today, and they go, say, listen, I get referrals from 20 different orthopedic surgeons all over 5 counties. They do great, but for some reason, the patients that come from your clinic are way different. They're more nervous, more anxious, they're freaking out. That bothers them. They don't want to look different to their peers. And then they'll ask me, what's going on? I say, well, I'll tell you. You're scaring the living daylights out of them. Now, you and I can have an adult conversation about what the bulging disc, whatever, but the bottom line is they're scared, they're nervous, and then they will inevitably ask me, does everybody know this? I say, well, yeah, they do. They care about their image. Now, every now and then you have the physician they won't listen and whatever, and that's fine. Then what do? We treat the patient the best way we can. You pick them up again, you drive them. And like I said, the best thing is ultimately for the patient to buy into your program. And how do you do it? By seeing results. And it's not just results about my pain is better, my function. You listen, compassion, empathy, all the right stuff. Those matter. They really do. There's I shouldn't do it on a podcast, but there's these sneaky little things like, you have a follow-up with your doctor next week. Hey, how about you call them and say, you know what, I got some conflicts. Can I move it 2 or 3 weeks on? Just because we're making really good progress. You do these little tricks of the trade thing, and it's usually not a problem because I treat chronic pain, and the follow-up, if you move it 2 weeks, is not the end of the world, those kinds of things. But I want your listeners to know, and everybody knows this, you never cut down another healthcare provider, ever. You will always lose. You never do that. You always take the high road. Sally is a great PT. She's done amazing training. I know she's very heavy in the sacroiliac joint stuff. I'm not, and that's okay. We're all different. I do more pain stuff, whatever, but you never cut them down. It never works that way.
As I've matured, I've gotten much better at that. I can say that I have definitely gotten myself in trouble. Yeah. My UIC colleagues can attest to that. And I think what you just gave is just such a tremendous, that recommendation is just such a tremendous amount of recommendation to enhance your practice, but also enhance your reputation within the community. What advice, Adriaan, would you give a practitioner who is right now considering fellowship?
It's hard. I've actually had several young people come up to me during the conference, and it's such a hard thing. It's a blend between family life, learning, studying, money, all those kinds of things. It's hard for me to answer. I'm a lifelong learner. The day I got my PhD, the next day I told my wife I'm gonna sign up to do my PhD in psychology, and she about killed me. So I would always learn. I love learning. I think when you stop learning, you go backwards. Fellowship, obviously, you're talking about advanced skill sets here. As Joel Bielowski showed us this morning, as Chad Cook talked about this morning. Just look at it, and if it's stressing you out right now about doing it, don't do it. Work a little bit. We need more clinicians to also come in, not somebody that just goes from PT school to residency to fellowship. That's a little bit green. So I don't have a problem with people to go. Just go. It's okay to take a year or two and get your life. It's okay to go out for a little while and then do fellowship. For those that got done with, say, a residency the next day, like what's next? Go to fellowship. Those are options, and they're beautiful options for what you want to do. It's hard for me to speak anti-education, but I also understand PT schools are expensive, residencies are added cost. We have to make the best decisions we can. But the cool thing is there's so many options. I mean, when I started therapy years ago, there's only a few fellowships. Now there's more, so you have more options. There's more on this coast, that coast, whatever. You wouldn't find me saying no. I would just say, just see where you're at. Make sure you're healthy. We have to be healthy ourselves, but keep learning. And if fellowship's the way you want to go, do it.
Mm-hmm. The advice that I tend to give people kind of agrees with what you just said. I've been a staunch person that you should practice for at least 3, if not 5 years before. That way, what you're learning in fellowship, you can reflect on those cases that have walked through, which is, experience, right or wrong, is going to be able to give you that background to compare against. So how might people be able to get a hold of you, Adriaan, if they want to follow up, they want to learn more about what you're doing? What's a good way to get in contact?
That's what, our group, International Spine and Pain Institute, is part of the Evidence in Motion Institute of Health Sciences. So ispinstitute.com is the easiest place to find our content. You can find me, everywhere.
So
Just search me, they're about everywhere. It's probably the easiest way.
Perfect. Well, Adriaan, thank you very much. I wish you best luck with the rest of the conference, and I look forward to hearing what you have to say and what you have to share with the profession going forward.
Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.